So next I'm going to be talking about cornea, ocular surface, refractive surgery, eye banking, and diabetes. And just as Dr. Mehti's talk was so perfect and so clear, mine is going to be ambiguous because we will confess that posterior segment people have done a lot of research, come out with lot of modalities, the way to treat, but somehow the anterior segment research has not been to the level it should be, and there are a lot of areas which are really my slide is not sharing, I think.
It came actually, slide did not come, but
Okay, I'll try again. It is not as it's not coming again.
we
So
just
it is
see the
not,
blank screen.
yeah, it is not as clear as the anterior segment people are.
Even the screen is not as clear.
No. Okay, let me try again. How is it? I mean,
Namrata, I'm seeing for the first time that
first time even I am also seeing. It's coming, sir, now.
Yeah. Now it has come. Dar slide bhi dar gayi.
So I will be talking, and it is good that we thought about it, because only then I started to see what was actually there as far as diabetes and cornea and ocular surface changes are concerned. Although we did have some idea, there are no financial interest in any of the products which are mentioned in the presentation. And diabetes, in more general terms, can cause dry eye, diabetic keratopathy, diabetic cataract, diabetes and glaucoma, diabetic retinopathy. And there are 5 layers, and I would be discussing in each of the layers and each of the structures which are shown here: tear film, epithelium, Bowman layer, stroma and corneal nerves, endothelium and Descemet's membrane. What are the changes which occur due to diabetes? Of course, most of it is research and may not translate clinically. So if you look at the alterations in the tear film, there's decrease in the tear proteins and neuropeptides. The inflammatory markers are increased. The osmolarity of the tears is increased, and glucose concentration in the tears is also increased, which may be responsible for impaired corneal epithelial wound healing. So this is just a schematic diagram which showed that how inflammatory factors, neuropeptides, metallic elements, tear proteins, all in diabetes mellitus on this half are increased, and this can lead to epithelial defect as well as features of dry eye, which is tear film instability, as well as hyperosmolarity. Now, when you delve more into the research, you find that there are still some changes, some tear proteins which don't change, which are highlighted here, like lactoferrin, albumin, lipocalin, lysozyme, and secretory IgA. But in general, they do increase. And the total glucose levels are about 10 times lower, but well correlated with the blood glucose levels after allowing for the equilibration. And the total glucose concentration also people have seen without diabetes. What is it in the tear film, which ranges from 0.05 to 0.5 millimolars, and 0.5 to 5 millimolars for patient with diabetics. So just like the glucose concentration increases in the blood, so does it increase in the tears as well. Now, if you look at the insulin levels, again, it is the same picture as is present in the blood. Insulin levels in stimulated tears of patients without diabetes is 0.2 nanogram per ml under fasting conditions. And when after a meal you check, it increases to 0.6. And there is something which is called as insulin-like growth factor binding proteins, which binds to insulin-like growth factor 1 to activate the cell apoptosis and anti-proliferation. And expression of this factor is increased in type 2 diabetes. Now, lacrimal function lacrimal functional unit also shows dysfunction because of the inflammatory damage which occurs to not only the lacrimal gland, but also to the meibomian gland, to the conjunctival goblet cells. And there is, as was being discussed, neuropathy element, which affects both afferent as well as efferent arms of the tear secretion. So all in all, it does lead to dry eye disease. Now, there is something which is called as diabetic keratopathy, and what are the clinical features or what is the spectrum? So there would be loss of corneal sensitivity, recurrent corneal erosions, dry eye, delayed wound healing, and neurotrophic corneal ulceration. And if you look at the other features also, apart from the ones which have been mentioned, there would also be endothelial decompensation. Now, this mainly occurs because of, like I said earlier, overexpression of cytokines, chemokines, and pro-inflammatory proteins and pro-apoptotic genes. So diabetic keratopathy is actually not a single corneal pathology or a single corneal disease, but encompasses all of them or one of them. Like I said, it is not as clearly defined quantitatively as is diabetic retinopathy. Maybe people have not worked on it enough. And this corroborates very well with the research which has been done mainly in the animal studies to see which nerve fibers are affected, and it is the A and the C nerve fibers of the cornea which have classically been affected. If you look at the epithelial cell density, that is also reduced in diabetes, and corneal Bowman's membrane also becomes thicker, and some ocular pathology which is discussed occurs sooner in the spectrum of the disease than the classic clinical symptoms or the retinal disease. And I think that is what we need to figure out, that the corneal changes occur first or the retinopathy occurs first, and where does these corneal changes fit in? Can we, even before the retina people pick up the retinopathy findings, can we pick up something in the cornea even earlier than that? And then that way it is going to be a better marker, because retinopathy is going to occur later. Now, this is just to show how recurrent corneal erosions can occur, and these will have classically, they will stain with the fluorescein dye, and patient would have features of pain, redness, congestion, and watering, and sometimes these are really painful. Again, Juice 2 report has shown that diabetes is a significant risk factor for the dry eye disease, and patients diabetics have faster tear breakup time, decreased tear production, increased tear osmolarity, and greater rates of meibomian gland disease, as well as blepharitis. Of course, the treatment is only palliative in the form of ophthalmic lubricants, punctal plugs, medications which can be given topically or orally, which would include cyclosporin as well. Then autologous serum, amniotic membrane transplantation, lid closure. And the only drug which has been approved is Senegermin, which is, of course, as of now, not available in India. Now, bandage contact lens should be contraindicated in general. I mean, it's a relative contraindication for diabetics because this can cause infection, and NSAID should never be given because of the possibility of corneal melts and the possibility of corneal perforation. There is one study which looked at the use of topical insulin, which improves time to wound healing, and this topical insulin may have a role in future in corneal wound healing. And again, this was an idea which came just now. And as we see the ocular surface microbiome, although predominantly normal healthy corneal surface or ocular surface, you have Corynebacteria, Staph, Streptococcus, Acinetobacter, and Pseudomonas. But in diabetics, you have other organisms like E. coli, Klebsiella pneumonia, and Enterococci. And what is seen is that there's a higher positive culture rates and there's a greater bacterial diversity in diabetics. And you doing molecular analysis, again, different organisms like Sphingomonas and Ralstotonia have also been seen as compared to the healthy controls. And there was one study which said that there's increased risk of acute bacterial conjunctivitis in diabetics as well. Now, if you look at the nerves, I think that is the only thing which can be imaged, just like the retina people do the imaging of the fundus. The only imaging which we can do is of the corneal nerves, and the corneal subbasal nerve fiber length, density, and branching are reduced with diabetics. And this again, the nerve fiber length and the nerve fiber density can be a marker for diabetes, because this is also going to be affected by diabetic peripheral neuropathy and the autonomic neuropathy. But where in it will fit in the entire diabetes spectrum remains to be seen. Now, this is just to show that this is how, when there is no metabolic disease, the nerve fibers will look like, and the density is quite high. But as there is in pre-diabetics, this would decrease drastically. And in diabetes, there is a frank decrease of the nerve fibers. And the apoptotic keratocytes would increase in prediabetes and diabetes if you compare it with the state when there is no disease at all. So this is something where we could do research in future. Now, because of the various accumulation of the advanced glycation end products, there are two effects. One is the corneal thickness would increase even in well-controlled patients with where the glycosylated hemoglobin was less than 7, and duration of diabetes can be correlated with increase in the corneal thickness. Now, in the corneal stroma, again, the biomechanics become better, which is expected because of the accumulation of these glycation products. And because of this, I'm sure Dr. Pandav is going to be talking about it. There may be an overestimation of intraocular pressure, which may lead to a misdiagnosis of glaucoma. Then in stroma, like I said, there are going to be again changes because of the cross-linking that occurs and because of the accumulation of the glycation products. And this was a study where they looked at the peripheral neuropathy severity and found that this was much more in cases of diabetics, and they directly correlated it to the central corneal thickness. As far as the endothelium is concerned, the endothelial cell density would decrease. There would be more pleomorphism, more polymegathism in cases of diabetics. And the duration of the diabetes is well correlated with the endothelial cell density loss, polymegathism, and the pleomorphism. And this test is, I think, again, which can be looked into future, and that is cornea autofluorescence, because this has been correlated with the duration of the disease and the severity of the diabetic retinopathy, as well as the glycosylated levels. And this is something which we can look at in future for research. Maybe corneal autofluorescence occurs much before the diabetic retinopathy also, and can be used as a good tool to look at as a marker for diabetes as far as the eye is concerned. Now, this is just to show that the advanced accumulation of the advanced glycation end products occurs, which leads to release of reactive oxygen species and sorbitol accumulation, and finally stromal edema. Confocal changes I've already discussed, but just to show polymegathism and pleomorphism, you can see that these the cells are showing a change in the size as well as the shape in cases of diabetics. And this is again a study to corroborate the same, which has already been talked about. Then apart from this, even the limbal stem cells will show a change. There's a reduction in the expression of the limbal epithelial stem cell markers. Intraepithelial cystic changes are there. And again, this is something which has really not been looked at and can be a study in the future as well. As far as the contact lens is concerned, contact lens can be given to the patient who has diabetes. Only thing is the endothelial cell loss was more in cases of diabetics when you compare it with the normal patients. And it is important to educate patients with diabetes on increased risk of complications with the contact lens, more frequent follow-up, poor wound healing, reduced corneal nerve function, endothelial cell density, and changes in the ocular microbiome, which may lead to contact lens indicated corneal infiltrative events. And the current US ophthalmic guidelines do not preclude contact lens wear for patients with diabetes. Now, when you look at diabetes and refractive surgery, patients with diabetes have higher rates of incomplete wound healing after LASIK. And this occurs mainly because of, in one study, because of the unstable refractive error, which was associated with hyperglycemia. Patients with uncontrolled diabetes did have worse refractive outcomes. And again, if you look at the AO guidelines, it says that uncontrolled diabetes is an absolute contraindication, but well-controlled diabetes is a relative contraindication for refractive surgery. As far as eye banking is concerned, the donor corneas from patients with reported diabetes is not a risk factor for PK failure. But recent studies have seen that we don't take donor corneas from diabetics, especially for DMEC surgery, because there you can have more chances that the grafts may not open up because of the tight scrolls. But diabetes per se will not lead to increase in the graft failure. So this is what are the changes which can occur at the level of the cornea, at the level of the eyelids in pre-diabetes and diabetes. So notice that everything has been reported in diabetes, which I have already summarized to you. And this is actually a single slide summary. But in pre-diabetic state, these have not been evaluated or not been reported. And that is where what we need to really look at. And then I think there should be one more column which should be of diabetic retinopathy, so that we can correlate the corneal changes with the diabetic retinopathy changes. So this is very much what I've been talking about, that research in diabetes and eye has historically been focused on retina, and we do require to confirm the effect of diabetes onto the cornea. Corneal autofluorescence has a great potential, and so do the tear protein and the neuropeptide levels. And currently, the anterior segment care is only palliative, and it is not curative, like again our posterior segment surgeons who do a curative treatment of diabetic retinopathy. And we have no guidelines absolutely for eye care for patients with pre-diabetes, which needs to be looked at. Anterior segment mainly focuses on the patient's quality of life rather than the visual loss, and more related with the problems which can occur of dry eye, recurrent corneal erosions, epithelial defects, etc. So we do recommend that these things should be looked into future, and however, we recommend that routine assessment of ocular surface should be done, corneal endothelium should be done, and corneal confocal microscopy is again a great tool, and correlate diabetic keratopathy or cornea changes with retinopathy. So thank you very much for your kind attention.